afternoon, everyone. We will start with my topic as the first two speakers are yet to arrive. So I'll start the optic disc assessment tips for how to assess it. It's not advanced. Yeah, so you have to do a careful examination and keep an open mind. So, because whatever you see like glaucoma may not be a glaucoma at all. Evaluation of optic nerve head and RNFL requires a systematic approach. It improves the detection of glaucoma. ONH science is a highly sensitive and specific, high sensitivity and specificity for diagnosis of glaucoma. So clinical evaluation can be done with direct ophthalmoscopy, but it has a limited advantage. It lacks stereopsis. Stereoscopic examination can be done by slit lamp and non-contact lenses, particularly 78D or 90D, which are preferred. And you can use central part of Goldman size or band size 4 mirror also. Detailed drawing is always helpful. Baseline documentation is needed. You can have color and red-free photographs, stereo photographs if it is possible. Stereo photographs help in early detection of glaucoma. Normal ONH we know follows ISNT. So the cup is horizontal as compared to vertical. How to identify cup margin and neuroretinal rim? So you need to identify the age of the disc, that is scleral ring. Follow the course of the blood vessels within the optic disc and identify the inner cup margin. So again, identify the age of the disc, observe the blood vessels, how they come over the neuroretinal rim, and then you will be able to identify the inner. The next clue is the circumciliary vessel, because normally they are on the inner margin of the cup, that is NRR, and you would be able to find out the NRR very clearly. So there are various signs of glaucoma. The physical signs of optic nerve size and shape are important. We may have different type of optic disc in normal population. So normal small disc will have a small cup, medium disc will have a medium cup, and a larger disc will have a large cup, which affects the neuroretinal rim when we evaluate. So small disc, how to identify them? So you first identify fovea central disc and the disc diameter, the cup that is a circle over the optic nerve, and find out the disc diameter. And if the disc diameter is around 3, this can be a small disc. A medium disc will have a disc diameter of around 2, and if it is less than 2, this can be a large disc with a large cup. So whenever there is a high CD, you need to investigate. Do not label immediately as glaucoma, but because this can be totally normal. Myopia also looks like glaucoma but may not be glaucoma, so you need to investigate. Maybe you have to do serial documentation of perimetry like this and conclude. Myopic dentate disc is again mistaken as thin NRR because of the atrophy, also temporal atrophy, but you need to document and have serial photographs. Dentate disc syndrome is a syndrome where discs are obliquely inserted and you can create a peripapillary like thing inferiorly. So this is a syndrome and definitely not glaucoma. This asymmetry can be an initial sign of glaucoma, but in a unilateral large disc and a large cup can be totally normal, whereas same disc size and a large cup with thin NRR can be abnormal. Vertical enlargement of a cup in a vertically oval disc can be totally normal, but if a vertical cup thin NRR along with a RNFL thinning like this, superior-temporal lid, it can be glaucoma. So pallar cup discrepancy is a pathognomonic sign, and you need to identify the pallar and cup, and if it is associated with inferior-temporal thinning of RNFL, this is definitely glaucoma. Cupping more than pallar, as you see here, and pallar more than cupping, you need to distinguish. Cupping more definitely is glaucoma, but pallar more may not be glaucoma. So here rim pallar in glaucoma is very rare, and you need to identify and evaluate this disc. This was a Ayurvedic physician who was on glaucoma and glaucoma drugs, and his perimetry and visual field defects were like this. But when MRI did, we found different findings in this, and this is definitely not a glaucoma. Concentric atrophy can occur because of the enlargement of the cup, and laminar dot sign can be seen as a fenestration in glaucoma because of loss of neuronal tissue. This is advanced cupping where you see pallar less than cupping, and very advanced glaucoma also you can see the thinning of NRR. Coming to vascular signs, there can be significant finding, and first sign of glaucomatous damage common in inferior temporal quadrant, and they need more aggressive therapy. If you see this, more found in patients with normal tension glaucoma. So bayoneting is a common sign where the optic retinal vessel, when they traverse the optic NRR, got different across 90 degree where there is an optic fade. So this is called as bayoneting. Bearing of circumlinear vessel, we have seen overpass cupping is when the vessels bridge over the cup and suddenly collapse into the cup. So this is a NVD, and this is disc hemorrhage, which is glaucoma. This is bayoneting with the large cup, and this is definitely a thinning of NRR with notching, which is glaucoma. This is circumlinear vessel, which is normal, and this is bearing, which is glaucoma. So coming to peripapillary changes, there can be slit defects like this, which can be totally normal. Sometimes the slit defects are more and they like coalesce and can form a defect. And this is a typical superior and inferior wedge defect. So diffuse RNFL loss is seen in these patients. So normal ONH, do you see this? But if you see the RNFL, you see that there is a page-shaped large defect. So you have to see the RNFL and NRR very carefully. Peripapillary atrophy, alpha zone atrophy is common and seen in almost all normal patients, but beta zone atrophy can be seen in patients with POAG and NTG, and it corresponds with the visual fields. So this is the beta atrophy which is seen in myopia. This is moderate glaucoma and advanced glaucoma. This is normal. This peripapillary atrophy. If you see the visual field and OCT, you can make out that the OCT also shows thinning, and visual fields show the blind spot, but this is because of the inferior peripapillary atrophy and definitely not glaucoma. Watch for progression. Watch for all the signs. If you can see, there is a splinter hemorrhage over here, and which is developing into the RNFL defect. So again here a small RNFL defect superiorly, but now there is a development of disc hemorrhage along with the inferior defect, and the left eye also the RNFL base-shaped defect is usually one side. The various optic nerves, which we call as anomalies, and here we can not differentiate if they have glaucoma or not. So coming to the different size, focal atrophy, bearing of circumlinear vessels, laminar dorsal, and inferiorly again bayoneting, thinning of NRR and alarm. So documentation is very important, which process will help you, and don't forget comorbidities because these patients are all elderly patients and they can have certain types of other diseases. Do not ignore large cups because they might be normal, might be having advanced glaucoma, might be having some neurological problems. So most important is note the disc size. NRR is important and not the CD. Check for palar cup discrepancy, find and observe vascular signs, evaluate RNFL defects, note the signs of progression, keep a high level of suspicion when the findings are atypical, and remember that patient may have more than one disease. Keep in mind that everything that looks like glaucoma may not be. Thank you.